Perfect.
Hello, ladies and gentlemen, NIC Global and even visitors and guests from far away. This is in charge, our professional development. This is professional development orientation program. And in fact, this is a groundbreaking event. This is our very first professional development workshop. And this is being led by Dr. Marco, and he is the director of education research at NIC. So welcome everyone. Please do mute yourself. This is time when we're ready to interact. Dr. Marcos will have the cue and we will go on unmuted. In the meantime, look into the chat and you will find a link for the pre-test. Thank you, everyone. Welcome. Dr. Marcos?
Thank you.
Audience is ready.
Okay. Thank you, everyone.
Thank you.
Let's get this rolling. Thank you, Dr. Niampu. We are I'm just like pleased and delighted to be here today. In this opportunity, and we're gonna spend some time today talking about quality and how quality impacts patient care, and more importantly, patient safety. Okay. To that end, I'm going to share with you a strategy or a methodology that is called the Lean Six Sigma. And we're going to talk a little bit where that Lean Six Sigma comes from. I am in terms of my background, I'm a physician, I'm a physiologist by training. I also happen to have a training in medical education. So at some point, I trained myself, or I trained through a master black belt as a Lean Six Sigma. So I'm a black belt in Lean Six Sigma. So using my background in medical education, we were able to transform part of this curriculum into healthcare oriented person to use it in the daily activities to be more efficient at what we do, which is taking care of patients. As always, I love to start with the quote of the day, and let's get rolling. The quote of the day: quality, it's never an accident. Quality is always the result of intelligent effort. That is quality right there. There's not such a thing as quality by mistake. Quality, it's always that result. In terms of Lean Six Sigma that we're going to talk today, quality is the major product, the main product of them all. And some of the ways to achieve quality, we're going to look into it, is through process improvement. Okay. And conceptually, process improvement can be taken down to a science. Okay. And that's what we're going to be doing today. We're going to learn the methodology, and we're going to talk about quality, why it's important. I'm going to get you into the Lean Six Sigma framework of quality improvement, some of the tools that we can use. And at the end, I want to make sure that we're learning. We're gonna discuss two cases. We're gonna break that down. It's kind of multiple choice, and then we're gonna go into summary and questions and the post test. Okay. Now, in terms of the objectives for today, specifically objectives, my attempt is by the end of the talk, you will be able to list the fundamental tools and methods used by those working in project teams and the problem-solving purpose of, and we're going to emphasize real-world healthcare system problems, okay? What you encounter in a daily basis. We're going to identify strategies and tools that can lead to higher levels of quality performance and minimizing waste. And we're going to learn about the the make methodology in Lean Six Sigma, meaning define, measure, analyze, improve, and control. So we're going to get into there. Okay, let's get into it. Let's imagine for a second that we're getting 99.9% of the time things the correct way. That's not bad, isn't it? I love to have 99.9% in every single test certification I get. It would be kind of almost genius mode. And that it's mean kind of a almost perfect number. Now, let's take that 99.9% and imagine if we conform ourselves when it comes to quality with that 99.9%. What will happen if I just conform myself? I just, okay, that's it. 99.9% is good enough. This will happen. 22,000 checks per hour will be deducted from the wrong bank accounts. Imagine that. Well, luckily it's not mine because I have nothing there, but it's anyhow. 12 babies born today will be given to the wrong patient. I'm talking statistics in the United States, and these are probably 5, 6 years back. 14,000 plus computers will be defective. 2 plane landings in O'Hare will be unsafe. O'Hare is in Chicago. It's a very highly trafficked airspace, actually, in Chicago. One of the hubs in the United States, same as Atlanta. Well, I know it's pretty much more than that, but airspace industry are the masters, one of the masters of Lean Six Sigma. We can learn a lot from them. Because again, in airspace industry, and I'm gonna get into that example shortly. We hear in the news when there's a plane crash and there's people dying. We hear that a lot, but I'm gonna get you into the statistics shortly. 18,000 pieces of mail will be mishandled, and you get the idea. This is one of my favorites. 291 pacemakers will install incorrectly. So it doesn't matter how much medicine, nursing, science we know. If we place the pacemaker wrongly, it's not doing its job, its main purpose. How about 20,000 drug prescription read incorrectly? Now, I want you to start thinking about mortality rates. And let me put these statistics here for you for the sake of comparison. This is in the United States. Again, these are leading causes of death. But I want you to pay attention to that medical error one. And that medical error one, it's very high. You don't see it right now, but you can take a guess. Now, if we go back, primary question. Anyone knows what is the death rate per 1 million flights in the world? You say, wow, 1 million flights. I mean, 20, 50, 100, 200 people should die. The death rate for 1 million flights. I'm not saying 1 million passengers, 1 million flights to this date, it's 0.36. That's it. The death rate for medical errors in America, it's way more than that. So it's more dangerous to go into an emergency room because you're looking for care than to go into the flight. Just let that to sink in. You're supposed to be safer in the emergency room because you're seeking help for your medical condition. Was that a heart attack or a broken leg or whatever that might be? But statistics tells us it is more dangerous to get into an emergency room than take a flight. In fact, medical errors are the third most important cause of death in the United States. Yeah, I know uh, errors are part of what we do. But if you go back and think about medicine, that used to be simple, ineffective, and relatively safe, but now it's complex and effective, but dangerous. So, from that perspective, from the perspective that errors, mistakes are the third leading cause of death, our profession, it's all about first, do no harm. Yes? So, imagine a police department, or imagine first responders, or imagine just a fire department that they go out there to the field, and from every fire or every 10 fires they extinguish, they start two more. Never ending, isn't it? Doesn't make any sense. But unfortunately, healthcare has become that. We are one of the major sources of patient harm in the United States and in the world. I'm pretty sure that the statistic is very similar throughout. It's kind of one of those universal things. Here's come quality. So what's quality improvement? Well, let's go to the definition, and then I'm going to go into practical examples. For the definition is the combined efforts of everyone, healthcare professionals, administrators, nurses, physicians, patients, family members, researchers, you just name it, to make the changes that can lead to better patient outcomes, better system performance, aka health care, and better professional development. But still, it's kind of a complicated definition. But we go to that. We're going to define quality improvement later in an easier way so we can remember. Now, let me taking you into this kind of approach. This right here, I'm showing to you, it's in a statistical model that we call this a Gaussian curve. So if we take points of data and we cluster them together, when there's a normal distribution of data, like the average, and when the standard deviation, the mean, the mode, and the median are in the same place, basically we have these nice standard deviations. So basically 95% of all the observations are within here, okay? 2, 3, or 4 standard deviations. But the farther away we go, it's something that we can define as good or better and worse. So let me start with this example with coffee, just coffee. Imagine I have a coffee shop, and then one of my customers come to me, say, Dr. Marcos, yeah, I want an espresso. I mean, we serve the espresso, we give the espresso, we give the regular coffee, and the customer goes, oh, shoot, this is too hot. Okay, and you start taking notes. Too hot. Next customer, please. Oh, this is too cold. I mean, what is this? Iced coffee. That's an insult. No, no, I want a better coffee. I'm taking notes. And we keep doing that. And we started with these coffee temperatures. Okay. And if we're talking Fahrenheit, okay, or in Celsius, but let's talk Fahrenheit for the sake of the example. We're talking 88 degrees, roughly, I don't know, 37 degrees Celsius. Okay. And then we have coffee was served between 75 degrees Fahrenheit and 92 degrees Fahrenheit. There's too much variation here. But then as we start doing this surveys with the customers, we went to 78 and 92. And then we get into 80. And then ultimately we went to 88 to 92 degrees Fahrenheit. So we went from this, a lot of variation, to very narrow variation, perfect coffee temperature for the taste buds. So in the US, we have this place. Oh, if it's an international franchise, actually, Starbucks. I mean, I'm not a fan, but Starbucks coffee, something that is very curious and peculiar. And if you be in Starbucks, follow me. You ask for coffee in Starbucks, say espresso and Americano, like regular coffee. It doesn't matter what city in the world you ask for the Starbucks, it's gonna pretty much be the same experience. And you know, one of the components they have, the temperature of every single Starbucks coffee in the world, it's served between 88 degrees Fahrenheit and 92 degrees Fahrenheit. That guarantees that the experience for each of the customers is exactly the same. What they did, they decreased variation. They decreased variation. So they went to something that was a great product or a good product to a better, best product. So that variation, they narrow it down. Okay. So most of those coffees are going to be between 88 degrees and 92 degrees Fahrenheit. And as we decrease variation, most of those coffees are going to be right in a sweet spot, increasing quality and the experience of the coffee drinker. So Lean Six Sigma, it's all about that. It's about eliminating those weights, eliminating variation, narrowing down to become and perform better at what we do. Lean, meaning efficiency, sigma are standard deviations. So 6 standard deviations implies that you want to have an error every 4 million times. So if you have a Lean Six Sigma coffee, there's going to be a coffee out of the temperature every 4 million servings. That's a lot of coffee. As opposed to, we think about the 99.9%, you will have a bad coffee every 100 or 150, you will have 1, 2 bad coffees. Now, in Lean Six Sigma, we think about an error, a mistake, every 4 million times or processes. Okay? Interesting, no? Interesting. So can we call this a science? A good question. Well, listen, you know what? Starbucks took the coffee to a science, the temperature, less variation, less waste, better product. Can we translate that to healthcare? Into less waiting times, more efficient surgeries lead to less post-surgical infections? Can we take that knowledge and use it to improve? Yes, we can. So first, we need to have the overall subject matter knowledge. We know that medication A, it's good for pain. We know that medication B, it's good for blood pressure. We know that medication C, it's good for um, um, dialysis patients. Why we're not giving those correct drugs to the right patient? So that's, on the one hand, we have the subject matter knowledge, what we know about that specific process that we're doing every day. Hey, you have a patient coming in and you want to measure the blood pressure. We know that. We know how to measure the blood pressure or break the blood pressure. So what we do in the science of improvement, we do it the right way, the best way to perform it. Now, if we take that subject matter and we take that knowledge for improvement, we get into the model that leads us into quality, minimizing potentially errors, optimizing healthcare. So earlier, okay, I mentioned to you that we will talk about quality and what quality is. And here's the definition. Process used for identifying areas within systems that create waste, redundancy of effort, or suboptimal performance. We implementing some changes to improve those systems. Now, I'm gonna I'm gonna really facilitate the definition for you. Quality improvement is the relentless elimination of waste. Pretty much what we're doing here. Now, I want you to, whatever you're in the world right now, repeat after me, relentless elimination of waste. Okay? Now, I want everyone to unmute very quick. Unmute. Let's unmute. Let's unmute. And at the count of 3, we're going to say relentless elimination of waste. Quality improvement is relentless
elimination of waste.
Okay, here's the thing. I have an issue with that relentless elimination. That was very weak. We need effort. We need hour. So we're gonna do it again. I'm gonna give you a break. I'm gonna give you an opportunity. If not, you don't get a certificate today, okay, of participation. So unmute. And at the count of 3, we're gonna define what quality improvement is. 1, 2, 3. Relentless elimination of waste. Oh, now we're talking about, you see, you're getting there. You're getting your certificate. Okay, thank you very much. Let's continue here. Relentless elimination of waste. That's what we're doing in quality improvement and Lean Six Sigma. So I want my coffee always at the same temperature because it offers me the best experience. Here we go. Now, taking that into account, we need to know what waste is. And there's a very important definition of waste in Lean Six Sigma. In fact, there are a different weights with all the variations that can it contain. And I want you to follow me through this because they may seem too industry-like, but we encounter these every single day in our healthcare field. Like, for example, defects. There's some defects in the process, or there's some defects in the materials we use that can lead to waste. Okay. Many you have, for instance, you can have syringes, and once you open one of these, this is not working. This one is not working. That's one of the wastes. Overproduction, it's critical. It's, I want to say, one of my favorites in healthcare. Healthcare has so much waste. In fact, it's considered one of the most wasteful industries. And interestingly, we're living with human lives. But as a system, the process of different aspects is very wasteful. One of those wastes in healthcare, it's overproduction. Overproduction. That's an excess supply beyond the requirements of the next process. Sometimes we have over documentations when we ask a patient, are you allergic to any medication? And then next time around, they come to the same clinic, to the same visit, and they ask the same question again and again and again. That's kind of an example of overproduction. How about wait? Waiting time. Waiting time is a standard of quality. So average waiting time in an emergency room is one of those quality standards. So waiting, it's a huge waste, huge waste. Okay. So that's why we have the triage to identify those patients that if I act now, I save them. It doesn't matter what I do, they will be safe, or it doesn't matter what I do, they will not be safe. So of course, we don't use the Napoleonic methodology these days, but triage is about identifying those at high risk and act on them to avoid the waiting, which is a waste. Non-utilized talent is interesting because these come more into the human resources. So if you're part of a team in nursing, that happens a lot. So when you're working as part of the team, you don't necessarily assign the tasks, and this is more for you, nurse managers and nursing leaders. You need to know how to identify the talents within your team to assign the tasks accordingly. This, it's an art by itself, but there's a science behind it too. Excess processing with the excessive documentation we have these days. Motion is a huge waste. So we have done projects with physicians and residents and nurses to optimize how many steps they do when they are performing their task in a day. So we can save steps, but when you save steps, you increase the performance of the method because you're rounding faster and you can provide more help to the patients while also minimize waiting. Inventory. Inventory could be also with personnel. Inventory is one of those also that is very, very hard in healthcare because lack of personnel. Okay. And transportation, taking things from one place to another can generate waste. So those are the 8 major wastes in Lean Six Sigma that we consider. Um, and I want you to again take some time to look into these and think about how effects or transportation or overproduction or motion affects the works I do every day, leading potentially to a healthcare waste. Okay. By the way, it's important to mention here that Lean Six Sigma comes from industry. So actually, the Toyota company was one of the proposers of these methodologies inside the production line. So most of the methodology, it's more kind of a structure like in an assembly line. And it's also meant to do quick changes right there in front of you. Okay. Right there. So we're going to get into the mic model and talk about that. Um, Later on, we're going to do that. Okay. So far, so good. Let's go to how we use the scientific method before we get into Lean Six Sigma. Yes, one of the key features here is to be able to measure what we're trying to improve. Important things in life we cannot measure. But quality is not one of those. We can actually look at ways to measure specific aspects of quality. We can measure the temperature of the coffee. We can measure how many steps we take. We can measure how noisy an ICU, intensive care unit, is. We can measure the time the patients spend in the waiting room before they are called in an emergency room. So the aspects that we identify to try to get into improvement are aspects that needs to be somehow, some way measured. Okay, and then we can go into that. Collection of data. I mean, data are many. If you don't have one data point, it's not data. It's one point. You need two or more. And the formulation of hypotheses. But those hypotheses virtually comes more into what improvement needs to be done in order to improve the model. Good. So let's start with an example here. Let's talk about what we call the quality gap. Okay. So if we go from the theory to some more practical concepts, it's okay. I want to use methodology in Lean Six Sigma to improve certain aspects of the care I provide. What aspects I can improve? Well, we need to identify a quality gap. So in healthcare, there are multiple ways to identify those gaps because usually they are standardized. So if you think about it, whether you are in, I mean, it doesn't matter what country you are, your health authorities, they set some standards of care. They say or determine the waiting time national average should not surpass 45 minutes in an emergency room. We should have a level of mortality post-surgical less than 1%, and so on and so forth. Now, by the way, those quality gaps are basically, this is the standard that is required. Patients should not wait more than 45 minutes to have that decision to admit when they're in the emergency room. 45 minutes. But let's say in my hospital, they're waiting 55 minutes. So there's a 10-minute gap in that quality. So in this example that I'm showing you, a this was a hospital system that they were looking at cholesterol checks or cholesterol screening, and the percentage of patients, 1875, with a cardiovascular disease who were discharged after an acute myocardial infarction with documented LDL results within 12 months. Okay, so they found that only 56% of the time the patient was screened for LDL, for cholesterol levels. And then at that time, and that was considered one of the major cardiovascular risk factors. That's not been changing a lot, but here we go. For the sake of an example, they wanted to increase that to close to 100%. Okay, or they want to push it over at least 70%. So they created a project to pretty much enforce these LDLs results or document or those patients that they don't have one, try to access them. And after that, they came out with a 78%. So roughly 20% improvement in before and after that kind of particular project or process improvement. Now, here, this exemplifies something very important. The science of improvement and the science of knowledge are different things. And I'm referring back when I was looking at the knowledge tells me that potentially LDL monitoring could be one of the things to identify patients at increased cardiovascular risk. In science of improvement, I want to have more patients screened. Does that mean I'm going to save more life? I don't know. I don't know. That is a research project. That is not quality improvement project. You see, my hope is as I identify more patients, with high LDLs, I can proceed with the corresponding treatment for those particular patients that will catch more in the population. So in population health, um, even small changes in a big chunk of the population lead to overall big changes. So that's what um, that means. Um, but quality improvement doesn't necessarily equate to making strides in terms of healthcare or saving life. Okay, they don't necessarily to be hand in hand. However, however, how about minimizing medical errors or identifying those that may need that service? That is a completely different conversation. So in quality, we're focused on basically ameliorating or reducing that quality gap. Okay, good. So far, so good. So we're about to get deep into the Lean Six Sigma methodology. I just want to show you very quick. I'm going to glance this and we're going to take a break. Okay. And we're going to continue 5 minutes or so. These are some of the methods and tools for science of improvement. Okay. By the way, Dr. Niepu, we had this conversation before the meeting today. I'm going to provide for you all a folder. It's going to be a link with a folder with some of the materials today, including the slide deck. So if you want to study the materials later on, there's going to be also a book. Okay. Don't tell anyone that I gave you that book because it's got there's going to be a PDF, an electronic book on quality improvement, the rough science of quality improvement. There's going to be some articles there that I'm including, plus the slide deck for you, for your perusal. You can use it. You can make it your own. It's basically for your study pleasure if you want. Um, there's a model that is used for quality improvement. This model for improvement is called the plan, do, study, act cycle. This is a simplistic way that is usually used in nursing when it comes to adopting change, making plans to create some kind of cultural change. Specifically, when we talk about quality improvement, it's there for you to see and to compare and contrast, but we're going to focus on the DMAIC model of Lean Six Sigma. So we're going to get now into the Lean Six Sigma. So what I want to do now, I want to take a quick break, probably 5 minutes or so. It's close to, let me see, it's close to the 42 to the hour. Let's resume in 5 minutes, well, 47. What we're gonna do now in the next session is we're gonna get deep into the mic model. Okay, drink a little bit of water, let's stretch a little bit, and we come back in a bit. Okay, I'll be back in 5 or so. So far so good. Okay. Remember, there's no way you can handle a full hour continuous punishment of your ears with me. So I have to pause from time to time. Okay. I by design. I have to do it that way. Going back so far, what we have here is medical errors are the third leading cause of death. We talk about quality, what quality is, and we put that is responsibility of everyone. But quality improvement, it's pretty much the relentless elimination piece. Then we look into the science of improvement. Then we look into knowledge base, and what that means is, I know the patients that needed a pacemaker for their heart, but if I install those wrongly and they don't put the right settings, I'm not doing my job. Okay. And then we kind of switching into a specific methodology, plan, do, act, model. But we are now going to get into Lean Six Sigma territory. So this is when it gets interesting. Inside the Lean Six Sigma methodology, we have the MIC framework that basically stands for define, measure, analyze, improve, and control. It's data driven. You don't need to be a statistician. Let me tell you this. Uh, but there's sort of simply or very unsophisticated tools that you can use. Okay, and then it's data driven. Data driven. Okay. Uh, Let me meet two people here. It's data driven, and it's part of that Lean Six Sigma processing. So let's start with that, and let's explore each of the components of the Lean Six Sigma. First thing, Houston, we have a problem. You need to define the problem. And that phase involves defining the problem, understanding why is the problem, setting the project scope. You need to have clear goals. You have to have smart goals. Okay. They need to be specific, measurable. We need to state what needs to be accomplished by the end of the project. Okay. So we can define a problem as, hey, we have in this institution a very high incidence post-surgical infection. Very high incidence of what is 3 times the national average or 2 times the national average. Those need to be defined clearly. Okay. Once you establish and you have defined the problem, okay, then you start working into the other aspects of it. Then you need to establish how you know as you move into your product, into your project, you're impacting your outcome, you're impacting or you're making strides to improvement. Was that decreasing or increasing a metric? Remember earlier that we talked about the cholesterol checks? They wanted to improve, they want to increase the number of patients. They have a well-defined measure. Time measure. Less accidents, number, less accidents, measure. Less medication errors, less documentation mistakes, less orders that needs to be signed. Okay. Many of these process improvement measures, we call them key performance indicators, and we to identify these metrics in hospitals. Falls is one of those key performance indicators. We want to have less falls in hospitals. So what we do, okay, to make that happen through a Lean Six Sigma methodology. Usually inside the measure, we establish what we call the future state. And the future state has 3 components. Number 1 has the directionality of the change. We want to improve, we want to decrease or increase the measure. We want to decrease the number of falls in the hospital. We want to increase the number of successful surgeries. We want to decrease the number of patients that wait over 15 minutes. We want to increase patient satisfaction. So we call that directionality. So the measure should have a directionality up and down. The only way to do that is as long as I can measure it. Then come magnitude of change. I want to increase or I want to decrease the number of falls by 50%. So that's the magnitude of change. And then it's time bounded in the next 3 months, in the next year, in the next 5 years. So you have the measure that is tied to your outcome, and the future state of your measure needs to be defined with directionality, magnitude, and time bound. Similar to SMART goals, very similar to SMART goals. They have to be specific, measurable, attainable, um, that we can actually do it, viable, and specific. So we want to decrease the number of patients that fall in the hospital by 50% in the next 2 months. That is an example of the future state. Then we come to the analyze portion of it. There's plenty of tools that you can use to do that analytical portion, but I'm going to just focus probably in two today, okay? Which are pretty much easy to use in daily today. The data analytics in this era, this day and age, it's just amazing. The tools that we can use for data analytics. Now with AI, I mean, we can complete analytical projects in a matter of minutes compared to hours or days. Um, most of the decisions that we make to apply to a process improvement, they need to be fed and driven through the analytical portion of the process improvement or the DMIC model. Then we go to the improve phase. So improve phase is based on what you analyze, based on your analytics, what solutions you can implement. Many times we call this phase the countermeasures phase. Countermeasure phase. What we can do to avoid more falls? Well, we have to make sure that we identify patients at higher risk for falls. We need to make sure that those patients at higher risk, they have, let's say, wearing socks specifically to avoid the falls. We need to pay more attention to those patients and have additional safety measures around their rooms. These are the phase that there's creativity involved in it, but it's ultimately data driven. Data driven. And lastly, okay, you analyze, you define the problem, you know exactly what you're dealing with. Let's say falls. Let's keep that example. You can measure that by the number of falls that you have in a week, in a month, so on. Then you did your analysis and you identified potential root causes of that. Then you create an implementation plan, but now it comes to control phase, and the control phase is project management. It's basically how you make sure what you're going to do, what strategies you implement to make sure that your countermeasures and your process and your planning, it's taking place. This kind of execution, I want to call this compliance. This is what I call compliance. So, oh, we're going to make sure we identify the patients at higher risk of falls. How are you going to do that? Oh, every single patient that comes through the emergency room or is hospitalized will have an inventory to assess risk or an assessment to measure the risk. Perfect. Okay. These process controls, procedures, and monitoring system. I want to see this is the compliance base of the mic. Okay. Now, in the model of improvement of the mic, if you want to even simplify it a little bit more, and you can keep it science of improvement, you can use the why, the measure, and the how. So what you want to accomplish? It's like define. I want to decrease the number of falls that we have in this hospital. and I'm the administrator, or I'm the nurse leader in my hospital, in my area. I want to really decrease the amount of falls that we're having here. How you measure that, again, in this example, is very simplistic. It's just number of measures. So there's no gray areas here. It's either you fall or you're not. That's it. There's no half a fall. um, Sometimes there's some qualitative measures that you need by nature. You need to kind of a quantify, and you can produce or at least a surrogate of it. Okay. So the bottom line here is make sure that even if your quality measure is somehow subjective, try to find a surrogate that is quantifiable. Okay. That's the best way to indicate if we're moving in the right direction. Okay? And finally, how are you going to do it? How are you going to do it? So this is the implementation and control phase blended in. Okay. Always remember your future state, your measure needs to have the directionality, magnitude of change, and time bounded. So when you revisit 1, 2, or 3 months down the road, and you look at your metrics again, you should be looking at the numbers to say, well, we were having 2 falls per month. Now we're having 1 fall per month. Is that improvement? Absolutely. That's a 50% improvement right there. Or depending on the way you look at it, 100% improvement. But then you can take that to maybe next level. Say, okay, we are going from 1 to no falls basically per month in our hospital. Good. So remember that aim statement, you need to come up with the definition of the problem and the measure. And then we need to talk about how or what we want to gain. Remember the future state. We intend to improve our rate of control hypertension from 45 to 65% in the next 6 months. So there's an improvement, there's an increase, direction, magnitude, and time bounded. There's another example, increase mammograms from 68% to 90%, and so on. Now, one of the ways that we can look into how improve a process and eliminate waste is by having a system to define the process. I do this all of the time with my mentees when I do a real life project in the hospital or in the clinic. The first thing is I ask them, define the problem. And they go and define the problem. Sometimes the problem cannot be well defined until we really understand the process we want to improve. Okay? So this kind of diagram, it's a very easy way that you can use as an example on how a main process works, and then a sub-process works as well, and so on, and a microprocess. So you can trickle down and take it down to the heat, basically, where I can make that significant, impactful change that can lead to an improvement of the overall process. And again, you will have access to these slide deck. Feel free to some of the slides, they can be printed out and used as part of your a process improvement or quality improvement project to draw, make notes. Okay. So let's say we're talking here about minimizing the time patients spend in the emergency room before they are taken in for evaluations. Let's say now we have that time, it's set at 30 minutes, and I establish a metric or I establish a future state. I want to decrease by 50% the time the patient waits before they get assessed or evaluated. Now, we need to look into this, the main process. First is intake, the patient come in. So you can do this in 1, 2, 3. Step one, step two, step three. Then inside those steps, you can look at inside if there's another step there. Again, I've done these many times. We do it live. Even if it, if I'm working in the lab of the hospital, I'm trying to improve that, or we're trying to improve the diets of the patients, and we want to get faster in terms of looking into how we deliver the food for the patient. Um, the instrument, surgical instrument, this is an interesting one that we have done before. We have placed the surgical instrument always in the same place, in the same order, all of the time. And what's interesting, because during the first month, surgeons, they were for the kind of same type of surgeries, they were taking this amount of time. As we start placing everything in the same place all of the time of the surgeries start to decrease in a very gradual way. But it was a very interesting project. Uh, it was roughly a 10 to 15-minute improvement or decrease in time of each of the surgeries. And as you know, if you can cut for any given surgery, if you can cut the surgical time, that implies more money for the institution. That's in the administrative and the business. But a uh, a shorter surgical times usually are associated with a better outcomes for the patient, faster recovery rates, less likelihood of infections and so on. So we defined that project at some point, basically taking the different surgical rooms and placing the things in the same place. And I mean, it was hard because every surgeon was a little bit different on what they want to place the things. But when we standardized that, it was fantastic. First day they were taking the instruments from one place, and then it was easy for they didn't have to do that shoveling in the head. It was a very interesting project. Here, I show you we call this Kaizen form. Again, you want to have access to this, so you can use pencil or pen, and when you start your project right there, let's say you have this issue in the middle of your work shift, and you seeing that there's more patients complaining of noise in the ICU, just to say something, or patients complaining that it's too slow the emergency room. You can quickly tackle and make notes. Let me define the problem here and how it's impacting the business, or in this case, how it's impacting my emergency room. What are the root causes of the problem? How can I measure it, and so on? So each of these components is defined prior in the earlier slides. Okay. Um, but this is a very good way to look at it. So if you, as you go, you answer these questions, you come up with a quick quality improvement Lean Six Sigma like project. The essence, the soul, and the way it was developed was pretty much this way. It was This was to do right there in the assembly line. Toyota Motor Company, and boom, there's a problem. Engineers ran that way, took their Kaizen form to their pen. They start making quick observations. Okay, let me define the problem. How this is impacting my service, my patients. Are they getting annoyed? Or, um, what is the extent of the problem and how I can measure it? Ask yourself that question. How many? How much? Time, space, overproduction. In measures, it's also nice to look into the waste. If you can identify the waste, then you go into that analytical phase right from the back. After all said and done, what will be your scenario, the future state? Remember that? The measure, the directionality, the um, intensity of the magnitude of change, and time bounded. Then analyze, can you measure the causes of the problem? The causes of the problem. Patients with insufficient records, patients that are a high risk that have not been tagged in their bedside as high risk, patients that are high risk and they don't have their safety socks to avoid falls. There's a very nice rule that applies to life called the Pareto rule, or the was Pareto was a economist scientist, the early 1900s. He developed this theory that was pretty much true, that 80% of the land in Italy and 80% of the wealth in many countries were owned by only 20% of the population. Okay, that's the Pareto rule. In healthcare, this applies a lot. You can look and usually identify one or two things that is impacting over 60, 70% of your problem. I'm going to give you a very practical example here in the US when it comes to Social Security and insurance. Here, the major payer in terms of medical insurance are the centers of Medicare services, Medicare, Medicaid. This is kind of the Social Security like insurance that covers many people over the age of 65, pretty much everyone. Okay. It's interesting that most of the cost of the patient that cost the most for the CMS, okay, the patient that spent the most money in healthcare correspond to less than 10% of the whole population. Just think about that. Okay. That 80-20 rule, it's very well applicable, and I definitely want you to think about that. Inside the 20-80 rule, it's that, you know, interestingly, 80% of your happiness, it's only found less than 20% of your life. Okay. Oh, Dr. Marcos, that doesn't add up. 80% of your happy moments, they correspond to less than 20% of your total lifetime. Yeah. Now, going back, I have here an example of a project that we worked some years ago in the hospital. This was about delaying schedulings in the surgical room. Delays and canceled surgeries are a pain for the organization, are a pain for physicians, are a pain for the nurses. They're getting ready and prepared to have the patient in. Where's the patient? Oh, no here. Well, what do you mean? Man? That was a mistake. Mistake? What kind of mistake? Okay, let's go there. So we define the problem this way. There are delays in scheduling and lack of implementation of a standard global scheduling process. Every surgeon will schedule their patients whatever they want. So we went into the measure. Number of cases of cancellations of surgery or procedures, and that will do an increased rescheduling and add-ons last minute. It was a mess. So our team came in and we used the Lean Six Sigma approach to say, hey guys, let's propose this future state. We want to decrease rescheduling and cancellation by 50%. See the magnitude? The next 3 months. This was costing thousands and thousands of dollars to the hospital. Needless to say, all the time, spent, and waste to the patients. So we went into the root causes. And inside those root causes, we implemented the Pareto approach. Let me see what are the three main causes of rescheduling. So date of service change was the number one, but that was kind of the metric too. But then we look into wrong count. As you see, insurance testing or no shows were a very small amount of those rescheduling cancellation. So we were trying to target an implementation plan. Guess what we did? We focused on this thing here, wrong count. Why the patient was coming in for surgery? Hey, I'm Dr. Marcos. Oh, we don't have you here, dude. You should be here tomorrow. We have Dr. Cox here. What? We started avoiding those wrong accounts. We start working closely. What was the root cause? What was generating that change on wrong accounts? Okay. It was very interesting. Names, last names, patient numbers, they were using an abbreviated code that will produce a similar coding to two patients very often. So we expanded that code to two more digits, and that basically changed that basically was able to identify the patient in a better way. Okay? So we started to decrease these, and down the road we were able to increase or decrease the cancellations to the hospital. Okay, kind of happy ending. But again, what I'm trying to do here is, if you pay attention and you go to the analyze portion and you use Pareto approach or root cause analyses, you can identify what is really impacting your metric and just focus on that. Then these are some of the other things that we did. And again, in this case was a happy ending. Again, I talk here about the Pareto. Let me get into these root cause analyses. This is called a cause and effect diagram. Okay, I'm pretty sure that many of you are familiar. We use this a lot in nursing. The other way to hold this is the fishbone analysis. Fishbone analysis. See, here's the eye, okay, and this is the fish right here, very nice, and this is the bone. If still that doesn't make any sense, we can call it shark analysis, because here in the mouth of the shark and the teeth, it's eating its waste that is basically eating into your quality. And what is eating your quality? What is the effect? More falls, more reschedules, less efficiency, more time waiting in the emergency room. What are the leading causes of that? You can identify them. If you can find a number of a metric to those causes, you're closing in to your Pareto analysis. Because you will notice that one, maybe two of those causes will create most of the chaos. Most of the time, 80% of the time, the Pareto applies. We have the other day an interesting discussion, because I do population research. In populational health, as I mentioned earlier, very small changes in a huge amount of the population equate huge changes to the entire economy of that population. For instance, if we take allergy control, we take falls, and we decrease the number of falls in a huge population by less than one per person, that is going to be very, very impactful to the whole economy. So that's one approach. That approach needs numbers, needs massive. The problem with that approach is precisely that. So if you are doing a quality improvement project to improve the whole population of a state of Florida, in my case, or Nigeria, or a continent, or a region of your country, that is an approach that you can take. However, most of the quality improvement projects are localized in a single area, single hospital, single institution. That is not a good approach because you don't have the power of the numbers to create that small change in a large population. What you have is to identify that amount of patients that really need your help and target them. That's 80-20 approach in essence. Okay. So in quality improvement, if we're talking public health, populational health, quality improvement goes into small changes. At the individual level or institutional level, we need to think about what is creating most chaos here. Let me get rid of that. And that is 80-20 approach. So with that said, in the setting that I'm trying to avoid falls, the smart thing to do is not try to avoid falls in everyone. No, let's identify those who are at high risk and let me focus my resources in those at high risk because they're more likely to fall. Very different from populational dynamics. So keeping track, keep that in mind every time you're working on the quality improvement front at the institutional level. 80-20 usually works, usually works. I have here other examples. These are for you to study later on. I want to move on into see if we were learning today. You can review this later on your time. I'm not going to spend much time on them, but basically these are examples of facilities in the US looking into process improvement. This is not using the mic. This is using the abbreviated 1, 2, 3, define, aim, measure, and what they did to change the metric. This is another example of, this is the bonefish analysis. There are actually online tools that you can use to generate your bonefish analysis. You can type in and Google it, bonefish analysis or cause and effect analysis online, and you can come up with one of these. Okay, so far so good. Let's move on to the last portion of today, which is me asking questions and you answering them. Yes. Now, I have two cases here, not necessarily inpatient and admissions, but there are two case studies, okay? And there's a multiple choice after that. Let's do those, answer them, and then we're gonna go into our post test and have the closing remarks for the day, okay? Okay. Take some time to read, okay? And then answer the question below. I'm going to give you a couple of minutes to read it. I'm going to get off camera just a minute. I'll be back. Read and tell me what is the best answer. I'll be back in a second. What method in hospitals ensures specific work standards by comparing current state with future state through medical processes, flow charts, process maps? Another means creating an opportunity to evaluate if a specific current state is correct, if there are mistakes or aberrations. If you pick number C, even though it sounds redundant, you are in the right track. That doesn't mean that A is not correct. C, it's A is the second best answer. But what we're trying to do, it's in the current state, is you remember that process map? Let me go to the process map very quick. Here's the importance of the process map. So you have the current state. The very first thing is to define the process and see from there, wait a minute, this is not working the way it's supposed to be working, or it's supposed to be performing, or the way it was meant to be. Okay. Sometimes we start doing things in a certain way so many times, and when we dip into it and we try to do the process improvement and we go back into the drawing table, we define the process, but why we are signing notes with a blue ink when it was meant to be with black ink in the first place? Sometimes that is kind of an aha moment, and that we realize we are outside the SOP. That's why if you have process and procedures written for that particular process improvement project, pull them out, read them again, see if they need a change, or we have at some point derailed from the original plan. Okay. Okay, good. Let's go to the second case. And we're going to be close to the Q&A. Communication between primary care and hospitals are not standardized and inefficient thanks to the electronic medical record in the US. I can guarantee you that. The primary care practitioner, it's a burden for them. They need to do all the paperwork to send a patient elsewhere where the other guy is going to get paid. And it's not fair, but that's the way it works. Process of transitioning patients from primary care following hospital care can be challenging. Poor transitions of care, major causes of errors. In these poor transitions of care result in medical complications, increased hospital readmissions, errors. Some of the major hospitals in the northeastern region of planet Mars, occupied Mars, were identified by the volume of patients from Terra Primary Clinic. Qualitative methods, semi-structured interviews, were used to understand the current situation of care process back to primary care for patients who receive that care. A team of planet Earth residents are consulted to develop methods and solutions to this problem. Now, when you do qualitative methods, it's that we're quantifying them, okay? And then we start looking into the causes of a problem. And guess what? When you go into the causes of the problem, usually, there's one or two causes that create the whole problem. So which of the following tools can be used to identify the root cause of the problem? If your answer is B, you're not wrong, but probably A is a better approach. Now, let me stop you there. Don't get frustrated with me. Now, Dr. Marcos, you're cheating. Come on. There's no way we can beat him. Nah, you can't. Here's the thing. You can use a combination approach. You can start with a cause and effect fishbone diagram, and then try to quantify if you can assign how many times that is happening. And then when you reorganize those data, you end up with a Pareto chart. Excel has many tools to do this. Nowadays, you can use resources online to create Pareto charts and fishbones analyses. By the way, you can use artificial intelligence tools to do this as well. Many of these are free. ChatGPT 3.5, it does a great job. You can say, I want to create a root cause analysis or a Pareto chart, and I'm going to start to give you some data here. And it will quantify for you and it can generate a very nice Pareto chart. So if you don't want to get too sophisticated into the analytical portion, the easiest thing to do is to start with a cause and effect fishbone diagram. But if you can start assigning numbers to those causes, you will see that most of the problem is created or caused by one or two leading causes. So another principle to avoid waste when it comes to time and wasting time, it's beautiful to see this too. So you do a process map of whether process you want to improve in terms of shorting time, let's say waiting times. You do a process map and you try to quantify inside that process what step takes the most time. And you know what you do? You work on that step. This is similar to the law of chemistry that establishes the rate limiting step and enthalpy. So the rate limiting step is one step in a series of chemical reactions that determines the whole speed of the reaction. Same happens when you have your process map in front of you, quantifying times in each of the steps. You will identify maybe one or two steps that eats a lot, has a huge chunk of time waste that you can improve. The more time waste in a specific step you can find, the higher the likelihood of success if you implement your action, implementation, and control into that particular step. Okay, so I think we are all set. And let's go to the post test. So what I'm gonna do now is I'm gonna send you a quick post a link. Give me a second, please. First, I have to find it here. Okay, post test. Okay, then. Okay, good. So I'm gonna post this right here, this post test in the chat. Okay. And what we can do is we can also post it in WhatsApp if that helps. Uh, let's take a few minutes to complete these. And then we can discuss our results, and then we can go into Q&A, and then we can close this out. I think I'm going to stop punishing your ears now. Um, go ahead and complete your post assessment. Let's see how we're doing. Quick. Results are in. In the meantime, responses for the pre are in. And we did, when we started today, we have 16 responses and the average was around 35%. Okay. Kind of expected. I'm closing that out. Go to post. Minute here. Copy. One response. They're coming in. Let's use that form. I think the last one is the best one. As we prepare for the closing remarks. I mean, it's always, always being a pleasure to be here with beautiful people. Um, as I mentioned, we're gonna follow up in the next days, in the next few days, of this coming week. I'll be sending Dr. Niempu a link with the materials so you can download them, study them in your free time. And then I'm gonna post my contact information if you have questions or want to learn a little bit more about Lean Six Sigma and other tools that you can use. Um, I think these are the basic fundamental tools. This goes way more complex, I know, especially in the analytical portion of it. But I think it's a good foundation and it's relatively easy for you to start applying it in your daily activities. And hopefully, as we increase quality, we save lives and we are more compliant with the different processes in your institutions. Okay. Okay, are coming in the responses. Good. Okay, not to bother much more. Um, and then we are about to open the floor for questions. My very quick. I think the responses are coming in. Guys, I'm so proud of you. I have here close to a 40% improvement from the first one. That means that we're getting there. Um, Again, I'm sorry for the t-shirt you have. Um, what we can do, but it seems that you are getting there. Uh, Dr. Nyampu, I think I'm gonna open the floor for questions. If you prefer, you can type them in the chat, and I like them to be typed in the chat because sometimes I can identify a common question and I can address both at the same time. Um, so feel free to use the chat for questions.
Great job, Dr. Marcos. My goodness. This, for some were, this was a review. For others, it was the first time ever hearing about Lean Sigma, uh, waste production, quality improvement. But the way in which you conducted the training was just so incredible. I truly learned a whole lot. Love it, love it. Can't wait to review it and apply it.
Yes, yes. And by the way, if you're gonna start conducting projects of this nature, I mean, feel free. You can send me your Kaizen project note. I can give you some insights. In the analytical portions, I'll be more than glad to help with those. Um, it's something that we really enjoy doing. I think I have here. Let me see. Let me check the chat very quick. You have any questions? Feel free to post it in the chat. We can address them. If we don't have any question at this point, I want to take a minute or two to thank you all for giving me the opportunity to punish your ears for almost 2 hours. Um, I mean, I don't want to say I'm being with nurses in charge from day one. But every time I have the opportunity, I love to collaborate. I love to be part of the cause. Even though I'm not a nurse by training, I'm a medical educator, and I have worked with nurses as part of the healthcare team many times in my career. And I feel, and it's true, you're an integral part of the healthcare system. I think you are the blood that runs to the whole arterial tree and veins of the healthcare system. That's what you are. In my heart, I think you are kind of that. Physicians, they want to call themselves the brains of it, but I mean, those are the administrators. But you are the blood that runs through the veins and arteries, and you feed the entire system, the patient, the family members. Everyone depends on you. Basically, you don't have blood to a part of the body. You just wait to see what happens. You have an ischemia. That's it. You cannot get that part back. Um. Uh. And again, these are a some of the strategies that you can use and implement. And it doesn't need to be sophisticated. It doesn't need to be a 3 month thing. It could be right there. That day that things get a little bit complex, that patients are all over the place, gather the team. Okay, let's define what's the problem we have and use the tools. And the more you use it, right? Practice makes perfect. And you come with more creative, ingenious ways to do what you do, which is taking care of the patient. So we need to take care of. We need to eliminate waste, improve quality, and hopefully that together improve healthcare quality and save lives. Because we're in that business, we just know that that's our business. I don't see questions here.
Absolutely.
I
I
don't see
truly agree with
questions.
you. I think we should actually do a demo practice with how we can improve quality in NIC. You know, our onboarding process and all of that. Casey, what do you think? We
That's
can go out.
I took I took notes and I was thinking, wow, we should really start with our organization. I think that will be excellent. Dr. Marcus, we probably will be tapping into you.
I mean, I'm here actually these days. By the way, these days I'm working in a series of quality improvement projects. I am working with an institution to improve these are compliance rates on people taking assessments, written assessments, because kind of people they don't like to. They say surveys, and surveys, they're assessments. Um, and having people to answer those, it's becoming a little bit hard. Uh, but we are for the most part, I want to say that um, these projects, once implemented, uh, again, I think that the critical part is that analytical portion, okay? Um, because that will give you the lead into where you put your resources for implementation or for improvement. Uh, And again, days back it was a little bit you need some kind of sophisticated statistical tools, but not really. You don't need those kind of sophisticated tools if you kind of pay attention um to to what the data have to offer on your notes. But that's pretty much for now. Again, thank you very much, everyone. I see I see room for maybe follow up down the road, and maybe we can have other sessions that we discuss each other projects, and potentially would love to hear your stories if you're implementing this in your workplace or in your practices or in your hospitals or your clinics, and then see what results are you getting from it. I'm looking forward to that. That it's a number one goal. It's that we can make a change in the life of the learners that they implement, and they can improve the things that they do every day. But again, that's pretty much from my end. Um, but we can follow up later on, emails or contact me. I have also a web page. Um, a I think I show you a glimpse of it, md@ificar.com. I have a chatbot there. You can contact me through there as well. And then we can exchange any kind of interesting information or questions about Lean Six Sigma.
Thank you so much. Thank you, Dr. Marcos. I don't see we don't have any questions, but we do have a comment from Amika. She says, "Thank you for sharing your knowledge."
No,
So,
absolutely, a pleasure. It's a pleasure. And this is again, that was given to me same way. My master black belt, my trainee, I still have a great relationship with him. He is from the uh, a construction machinery industry. Interesting.
mhm.
And he was very inspiring to me. And I have worked with this model for some years now, from pre-COVID times, I want to say. And every time I have the chance to share it with other people in healthcare, I mean, it's a great pleasure for me. So thank you guys for giving me the chance to listen to what I have to say.
Thank you.